This week's lecture is on the medical information section of the health history form and pharmacologic implications. The medical information section is located just below the dental information section of the health history form, and it contains a lot of questions that are going to help you determine your patient's perception of their current health status and also their current medical therapy if they're taking any medications. And remember, this is the patient's perception of their current health status. So when they give this to you, it's their perception. What we need to do is investigate and be those detectives to find out what is currently going on with the patient. So knowing questions like if they're under the care of a physician, why are they under the care of a physician? Do they think they're in good health? Have there been any changes to their health? What's been treated? When their last physical exam was? If they've ever had an illness or been in the hospital in the past 5 years, what condition happened that did that for them? And then finally, if they're taking any prescription or over-the-counter medications, we need to know both, and that includes vitamins and your natural and herbal supplements. Anything that they're taking on a daily basis is going to be listed there for them, and then also on our medication form. So any yes response on this medical information page is going to influence how we treat that patient and how we decide what risk they are for treatment. Again, any positive response to these questions are going to require follow-up questions. We need to ask them why they're receiving care from a physician, what changes have they had in their health, what put them in the hospital or had an illness or operation in the past 5 years. It's really important that we know the date of their last physical exam. So if a patient says that they're in good health, they have a good perception of their health, but they haven't been to a general physician in 10 years, how can we be sure that their health is as what we say it? How do we know if they don't have undiagnosed conditions, diseases, illnesses? So knowing that the patient has had a physical exam in the recent years is going to be helpful in determining their risk for any other potential emergencies that they might have. And if you're going to be doing extensive procedures in the office, maybe not dental hygiene procedures, but maybe more invasive therapy, extractions, something like that. And if you're seeing them for extensive treatment and you've known in the past that their vital signs have been abnormal, they've either been elevated or really low, you may consider getting a medical evaluation. You might need medical clearance for them to be treated. So that's another reason why we're taking our vital signs. It's a screening for people who don't go to the physician regularly. So when we're using any of the medical information section, and it's not only on the bottom of the first page, but it's also most of the second page as well, by using all the information that we're going to be getting from that, we're going to be able to determine the risk of any kind of medical problems happening during treatment. We're also going to be able to see if there's any potential side effects of medications, either prescription medications or over-the-counter medications that we would need to know about. And we also need to know if there's going to be any drug interactions with any of the things that we're going to be using during oral care, for example, local anesthetic. And also we're going to be looking for the potential for cross-contamination in the dental office. If someone reports to us that they do have HIV or hepatitis B, knowing that from their medical information section is going to help us know that there is a risk of transmission in this case. However, no matter what the patient marks on their medical history form, we're always using standard precautions, and that's protecting us from everyone. We always act as everyone is infectious. All medications, both prescription, over-the-counter, supplements, vitamins, herbals must be investigated. That means that we must be looking them up and finding out how they work, if there's any side effects, if there's any interactions, and if there's anything dentally that we should know, any kind of oral considerations. So we're going to be doing this using a program called Lexicomp. It's installed in every laptop computer at your cubicle in your bays. And we'll be going over it in class on Wednesday, how to use Lexicomp and how we look up prescription medications and over-the-counter medications. We need to know before we start treatment, we need to know the drug action. How does it work in the body? We need to know the drug dose. We like to know the dose because the higher the dose, the more chance of side effects. The higher the dose, we know that the patient needs more control. So maybe they're having a high dose of a blood pressure medication because they need their blood pressure to be controlled, and a lower dose wouldn't work for them. It was too high so that a low dose doesn't work. We need to know if there's any side effects. Sometimes there's side effects that aren't going to affect our treatment, and sometimes there are. So especially oral side effects that might occur, and that's what most of our lecture is on today. We need to know if there's any drug interactions. So not only local anesthetic that I talked about, but potentially allergy concerns, any interactions with what we would use as far as antibiotics that we might prescribe, interacting with some of their medication, maybe sedatives that we would prescribe or anxiety medication, interacting with the medication that they're already taking. And then we need to know if there's any treatment considerations that we need to make based on the medications and the health of the patient. All right, so here again is the RCBC medical record, medication record form, and this is going to be what you fill out when you're in clinic with your patients. So when your patients have marked that they take medications on their medical history form, you're going to be putting in those medications to this form. So you are physically filling out this form, not the patient. You're using what the patient wrote on the medical history form to transpose it onto this and also add more information. So you need to have the date on every entry. If there's multiple medications, you need to have the medication, the dosage, the indication. So what are they taking it for? There's medications that have different indications. So someone might be taking a what we consider a blood pressure medication for a different reason, maybe for just cardiovascular health. It's not necessarily they have high blood pressure, but they have maybe atherosclerosis. So there's different indications, and the reference book that we'll be looking it up will give you all of them, and you need to write which one your patient is taking it for. Also, dental considerations, and this is where you'll be rating any side effects or any treatment changes that we may make based on the medications that they're taking. A lot of times patients fail to report their use of herbal, vitamins, or dietary supplements. And a lot of times it's just because they don't feel that it's necessary, it's not a prescription medication. But they do all need to be listed in the medications on their health history form as well as on the RCBC medication form. And they also need to be investigated. So as a safeguard to prevent against this, I'm always asking the patients, once they've filled out the form and I'm going over their medications, if they're taking any, I just overtly ask them, are you taking any herbal supplements, any vitamins that you've not already listed? And that just helps to remind them that we do find those necessary and we do need to know those as well. So use of these medications is increasing more in the last several years. We've often been hearing the term holistic lifestyle and natural living. You go through the grocery store these days and everything's organic and natural. So a lot of people are going towards that more natural lifestyle. And in the same way, they're doing that with medicine as well. They want to self-medicate and treat any kind of issues or problems with natural supplements rather than taking prescription medication. And because of this, sometimes they are not being told to do this by a doctor. They're just, maybe searching it on the internet, and that's how they get their recommendation. And a lot of times they aren't taking them as directed. So if they think one pill is good, maybe 3 or 4 is better for them. So if there's side effects of these medications, even though they're over the counter and they're herbal or they're natural, there's still some side effects. And if they're not taking them as directed, those side effects can be exacerbated. So there's a few common herbals that have side effects and interactions, and side effects that are more relevant in dentistry. One common vitamin is niacin, and that can cause postural hypotension, which is the first side effect we'll be talking about shortly. Cava, valerian, and St. John's wort. And St. John's wort is pretty common for people to be taking, but it can have an interaction with sedatives. And then finally, ginkgo, ginseng, garlic, and high doses of vitamin E can cause increased bleeding, which is another side effect we'll be talking about. Pharmacologic implications, and basically this is a fancy way of saying side effects. If you break the words down to pharmacologic, logic meaning pertaining to, pharma meaning medication. So pertaining to medication, implications or their effects, so side effects of medication. And again, these can be from prescription and over-the-counter medications. And there are some that can potentially, the side effects lead to emergency situations. And these situations that we're going to be talking about today are postural hypotension, excessive bleeding, hypertension, tachycardia, and arrhythmia, nausea, vomiting, and or GI reflux, blood dyscrasias, and blood dyscrasias are several different types of blood dyscrasias that we'll be talking about. So if any of the above are listed as side effects of medication that your patient's taking, you may need to be modifying your treatment to make sure that it doesn't lead to any kind of emergency situation. The first side effect of medication we'll be talking about is postural hypotension, and this is also known as orthostatic hypotension. So those two terms can be used interchangeably. They mean the same thing, but people use different terms, so we're going to use both of them so you're familiar with both. And this occurs when a patient is changed from the supine laying down position to the upright position quickly, and their body's physiologic response is delayed. And delayed is going to be our key word with postural hypotension. So the body's response is delayed. It's most likely to occur in elderly patients. It can occur in all age ranges, but most likely in elderly patients. And it's also most commonly happens due to a side effect of a drug or supplement. Patients that are taking blood pressure medication to lower their blood pressure can experience this, and also patients taking certain vitamins like niacin, like I said earlier. So going through the steps of what happens, the body's physiologic response. In the supine position, naturally the blood flow to the brain doesn't require as much blood pressure, so the body adapts by vasodilation. That's normal. The body is adapting to how you're positioned. Next, when the patient is resuming to an upright position, there is a delay in the body's proper physiologic response to the positional change. So there is a delay in vasoconstriction, and the blood pressure drops. So if the blood vessels didn't constrict and increase the blood pressure, you have a drop in blood pressure. Baroreceptors in the nervous system finally sense that positional change and start to initiate that proper response of vasoconstriction, but this can take a few minutes to occur. So during this time of the body trying to catch up to itself, it's delayed and it's not caught up, there's that low point of blood pressure. That's why this is postural hypotension, low blood pressure. And in this moment, the patient may feel dizzy, they might feel lightheaded, especially if they stand up really quickly. And in the next slide, we're going to talk about the potential for loss of consciousness. Okay, so like all of our emergency situations, our first try is to prevent it. So we can try to prevent postural hypotension by, if a patient marks that they have a medication that has a potential side effect of this, this is what we're going to do. We're going to be raising our chair to the upright position slowly so that their body doesn't have that delay in that physiologic response. And then we're going to have them sit upright in the upright position for 2-3 minutes before allowing them to stand. We don't want to have them even delayed further, and when they stand, them still have that low blood pressure and feel lightheaded and maybe lose consciousness. And you want to be near the patient when they stand. So you're going to let them sit for a couple minutes upright, and then you're going to let them stand, but you'll be nearby. They might need support. If they're still feeling lightheaded, they might need support, and they might need to sit back down. So as long as they're feeling okay is when we're going to let them to go. If we do not do this, and the patient is experiencing postural hypotension, it can result in unconsciousness. So if there's a decline in 20 millimeters of mercury or more in systolic pressure and 10 millimeters of mercury or more in diastolic pressure, that would be a potential for having postural hypotension. And when you are repositioning them, they can have a loss of consciousness. And it's the same reason why you have a loss of consciousness in vasopressor syncope, which would be inadequate blood flow to the brain or cerebral ischemia. So they're similar in that way, but postural hypotension is not caused by anxiety or fear. It's caused from a delay in the body's physiologic response. So if postural hypotension is listed as a side effect, you should ask some follow-up questions. Ask them if they've ever experienced this. Not every patient, if they have that as a side effect of the medication, not every patient actually experiences it. So ask them if that's ever been an issue for them. You can also choose to measure their blood pressure before allowing them to stand. So if their blood pressure is below 80/60, you want to wait until it rises to let them stand. So 80/60 is going to be your key number for allowing a patient to stand. And that's even still a very low blood pressure. And this all is in your book on Pickett, and it's box 4-1. So now, if a patient experiences postural hypotension and loses consciousness, now we need to manage the situation. So this is now the management of postural hypotension. We're going to be placing the patient back in supine position, and we can elevate their feet, just like in vasodepressor syncope. We're going to assess their airway, check breathing and circulation. Make sure it really is loss of consciousness from postural hypotension and nothing else as far as an airway issue. You're going to observe signs of recovery, making sure that the patient's not feeling lightheaded anymore. We're going to be checking their vital signs. Then gradually you're going to be moving your patient to the upright position. So first you're going to seat them at semi-supine, then maybe a little bit less than upright, and then all the way upright, again letting them sit before they stand. They can stand when their blood pressure is above that 80/60 millimeters of mercury. As always, if a medical emergency or loss of consciousness occurs, we're going to be documenting this in the chart. We're going to document when the event occurred. So was it when they were sitting or they just got to your chair? Or was it when they were leaving your chair? How did you manage the emergency? What did you do? What happened after the emergency? So where were the vital signs? Did the patient feel okay to drive home, or did they need to call a ride home? Were they still not feeling well? If they don't recover quickly from the loss of consciousness and they're not recovering well, then we need to consider, do we need to call emergency services in this case? So as long as they're recovering well, we can monitor them and escort them to be done with their appointment for the day. They can drive home, but they can choose, if they're still feeling not very well, they can choose to have someone come and pick them up. Again, this is also in box 4 point. Oh, actually, I think it's. Let me look in the book really quick. Yes, it's also box 4.1. The next side effect we'll talk about is excessive bleeding. This can happen from prescription drugs, vitamins, and herbal supplements, and they can all have that adverse side effect of increased bleeding. It's going to require us to, if a patient has a medication with the side effect of increased bleeding, we're going to have to be monitoring the patient during treatment to see if they're excessively bleeding or if they're having trouble clotting. Increased bleeding from drugs, there's 3 different classes of drugs that can cause excessive bleeding and why it causes excessive bleeding, and it's due to the drug action, how it works in the body. So the first one is platelet inhibition, or anti-aggregation. Means the same thing, it just means that these drugs work by reducing the ability of the platelets to stick together. So because the platelets aren't sticking together, the blood isn't clotting as fast. The next is the reduction in the formation of clotting factors. These are called anticoagulants, and they're making the blood thinner. So there's a disruption in how the body's clotting works, and that is how anticoagulants work. And finally, this one's least common, but it's the reduced number of platelets formed in the bone marrow. So if there's not enough platelets forming, it's going to impair clot formation. But this is a difficult one to identify. So here is a small list of common medications that can have excessive bleeding as a side effect. So first we have that class of drugs, that's the anti-aggregation drugs. Those are the platelet inhibiting drugs, or they reduce the platelets from sticking together, which helps to not make clots as fast. So first is aspirin. A lot of people take a low dose of aspirin for its blood thinning effects. A lot of people will call it a baby aspirin. That just means it's 81 milligrams of aspirin. Anyone taking a higher dose of that is probably taking a more therapeutic dose to have more blood thinning effects. It's also known as acetyl salicylic acid. So I want you to know both the brand name and the generic. Then we have Plavix or clopidogrel. And again, I want you to know the brand name and the generic. And this is prescribed to patients that have some cardiovascular issues. This is a very common blood thinning medication. And finally, 2 of our herbal supplements, garlic and ginkgo. These are the herbal supplements that have blood thinning effects. So patients are taking this, we need to make sure we know how much they're taking of it. And we also need to observe if there's any blood thinning or excessive bleeding when we're doing dental hygiene procedures. So I need you to know both the brand names and the generics as well as the supplements, and know that these medications are anti-aggregation or platelet inhibition drugs. So know the name and also what class it fits into. Okay, so next we have our anticoagulants. These are the ones that are going to reduce our clotting factors. This very, very common one is Coumadin. The brand name is Coumadin. The generic is warfarin. And how warfarin works is that it reduces the formation of vitamin K. If you remember back to your nutrition class, probably your physiology class, vitamin K, is a very helpful vitamin for clotting. You can find it in green leafy vegetables. So anticoagulants Coumadin works by reducing the formation of that vitamin K so that we don't get as much clotting. So that's how they work, and that's how they can cause excessive bleeding. So again, know that Coumadin is considered an anticoagulant. Okay, so if you have a patient and they mark that they are taking a prescription medication for a medication that can cause excessive bleeding, we need to consult the patient's physician. We need to find out what their prothrombin time or their international normalized ratio is. And what these two terms mean, we can know either or. Usually we like to know the INR because it's more accurate. But those are lab reports done by a physician, and it helps us know what kind of clotting the patient is. So this is how they prescribe these blood thinning medications to the patient, but they need to make sure they're prescribing them the correct dose. So they do these tests to determine if they're not working enough or if they need to increase their dose to make them work more. Or if the patient's blood clotting time is way too long, it takes way too long for their blood to clot, and that can cause a serious issue. Let's say if they cut themselves shaving and they're going to bleed excessively forever if they're taking too much medication. So these PT, prothrombin time, and INR are going to let us know how well the patient's clotting is controlled, meaning that they're on blood thinners, but they still are in control of their blood clotting. So for us, we want to have an INR of 3.5 or less, and that's what's going to be acceptable for performing dental hygiene procedures. If a patient is getting something more intense, something not dental hygiene, maybe they're getting extraction, the physician may recommend that they stop their blood thinning medication for 3 days prior, and then they resume it right afterwards. So that's more of for someone doing a procedure where it's going to be a surgical procedure and a lot of bleeding is expected, rather than a dental hygiene procedure, which is usually pretty well contained. If you observe a patient may be experiencing excessive bleeding, you need to determine if it actually is excessive. So when we talk about excessive bleeding, we talk about, a patient's going to probably bleed. Unhealthy patients that have gingivitis or periodontal disease are going to bleed when you clean their teeth. It's excessive when after instrumenting and you're already have been on maybe the other side of the mouth, if after 10 seconds they haven't stopped bleeding, they haven't formed a clot around those teeth, and it's still blood is pooling in that area, that would be considered your excessive bleeding. So you're going to stop treatment, and your first action when you notice this happening is going to be apply digital pressure. You're going to use your thumb and your forefinger, and you're going to take a piece of gauze between the patient's teeth and gingiva and your fingers, and you're going to hold it and apply firm pressure. And you're going to do this for a good amount of time without peeking, without checking. You're going to hold it for a minute, 2 minutes, and you can kind of get an idea of how long it's going to take. Then peek away after a few minutes. You're going to pull it away and see, did it stop? If it hasn't, you're going to apply more pressure. My husband is a periodontist, so he does surgical procedures all day, every day. And he is very, very frank with people that bleeding should stop with digital pressure. You really shouldn't need anything else. There's very few times that you can't control bleeding with just applying pressure. A lot of times people want to take it away too quickly. They want to peek to see if it stopped. Well, if you're trying to get a bleeding area to clot, you can't disturb it. You have to keep it stationary for a long period of time. So when we have something like a extraction or someone has surgery, we're telling them to apply that digital pressure, that moistened piece of gauze, for 30 to 45 minutes without moving it. And that's really going to help them to stop the bleeding. So if digital pressure does not seem to be working and we're not, we need to get it done quicker, there's some other ways we can try to stop the bleeding. So we can use hemostatic agents and break that down. Hemostatic. So hemo means bleeding or blood. Static means to stop. So blood stopping agents can be applied locally. So right where it's bleeding a lot, you can apply these hemostatic agents. So two of the more common ones are called gel foam and Surgifoam. And basically they're like look like a little absorbent sponge, very, very small, and you place it right to the area where the bleeding is. It's commonly placed into extraction sites, and basically it soaks up all the bleeding and starts to form a clot, and it helps your body form a clot. I know Surgifoam is what I use, or we use in my office, and it's made out of collagen, so that's what helps the clot. I'm not sure about gel foam, if it's collagen or not. Then there is, we can inject epinephrine into the site where it is. So local anesthetics a lot of them contain epinephrine, and epinephrine is a vasoconstrictor, and that's what's going to help control the bleeding. If you constrict the blood vessels, you're going to be able to control the bleeding. So there's always ratios when we're talking about epinephrine in local anesthetic. A very common ratio is 1 to 100. For trying to control bleeding, you want to do a little bit more concentrated. So you want to have 1 to 50,000 epinephrine. So there's either 1 to 100,000 or 1 to 50,000 that's usually used in offices, but that smaller ratio is going to be able to reduce the bleeding better. And also, this is something that we also recommend pretty frequently when patients have excessive bleeding, is tannic acid that is found in tea bags. Just a regular old Lipton tea bag that's in your cupboard can be applied firmly to the site. So you can moisten a tea bag and have them firmly apply it, just like would be applying gauze. But the tannic acid can help reduce the bleeding. So if no resolution occurs after all of these strategies, which it most likely will, there's very, very few bleeds that we can't control in the mouth. But if nothing else works, you can call 911 and seek emergency attention in a medical facility. Other small mentions of side effects that can happen are hypertension, tachycardia, and arrhythmia. So hypertension is usually a systemic disease, not necessarily a side effect, but it does have drug interactions and implications in the dental office. So like I said before, we use epinephrine because it's a vasoconstrictor, and it's in a lot of our local anesthetics. So the issue with that is that the epinephrine in the anesthetic can cause the blood pressure to be raised higher. So for someone who already has hypertension and the vital signs are elevated, choosing a local anesthetic without epinephrine, without a vasoconstrictor, is going to be a better choice, because you don't have that drug interaction of raising the blood pressure even higher to a point where it might be an issue. Tachycardia means rapid heartbeat. So it's when their pulse rate is irregularly fast, and it is a common side effect of decongestants. So if a patient has a cold, they might not have reported that they're taking a decongestant. If you notice that their pulse is elevated, you might ask them if they took a decongestant, and that could be why their pulse is elevated, or there may be another reason why. Finally, arrhythmia. Again, it's not necessarily always a side effect. It also can be a serious cardiovascular issue. So, and it's also the most common sign that precedes a heart attack. So you can detect an arrhythmia when you're doing a pulse if the patient's heart rate is irregular. But that's also something to note in your treatment notes, or in your next to your pulse measurement, that you notice that there may have been arrhythmia. So for any of these conditions, our management is going to be monitoring those vital signs. We're already going to be doing that, but you might monitor more frequently, or you might monitor before your patient leaves as well. And you're not going to be treating if the blood pressure is greater than 180 over 110. That's the ASA recommendations. our policy here, again, is greater than 180 over 100. If you notice that they have signs of hypertension or arrhythmia or tachycardia that is not induced by something such as a decongestant, you're going to inform the client of your findings and refer them to consult their physician about your findings. And again, blood pressure levels that are over 180 over 100 should be referred for immediate medical attention. This is seriously high, and they're seriously at a risk of a stroke or a heart attack. So they should be informed that it is seriously high and that they need to seek medical attention fast. If you've ever listened to the medication commercials or the prescription commercials on TV, you'll notice that at the end, really quick voices, they'll name out a lot of the side effects, and always nausea and vomiting are listed as a side effect. It's very common for that to be listed as a side effect of medication. And because many patients don't experience it and some patients do. So usually you can find out through follow-up questions if a patient has any bad experiences with certain medications. This is also important when we're prescribing medications. A lot of patients have had previous experiences, bad experiences with antibiotics. Certain antibiotics make them very nauseous or make them vomit. So usually patients are aware of what they can and cannot take. But you may just have them deal with it for something like a pre-medication for a dental appointment. They might have to take a certain antibiotic to pre-med for their dental appointment, and it may give them a little bit of nausea, and that's just a normal thing that they have to deal with once every while that they take this. GI reflux can also be a side effect, and it also can be a disease, and it causes burning and discomfort, kind of burning in your throat, in the esophagus area, or in the chest area. And this is when the stomach acid flows reflexes back up into the esophagus and pharyngeal area. Often when patients experience these side effects from medications, they'll take some over-the-counter medication to combat it. Something like Prevacid or Tagamet, Prilosec for GI reflux, or something like Pepto-Bismol for nausea, vomiting. If they're taking antibiotics that are give them nauseousness or pains in their stomach, a lot of time we can advise them to take their medication while they eat. They can also advise them to eat a yogurt, and that helps with the good bacteria in our gut to help fight off that nauseous feeling. But if we see someone that has acid reflux or GI reflux, it's best to treat these patients in the semi-upright position so it minimizes the reflux that occurs. It minimizes the acid that goes. Gravity kind of takes it. If they're in the supine position, gravity is going to take it up towards the esophagus and the pharyngeal area. So if you treat them more in the semi-upright position, that will be much more comfortable for them, and we'll have to modify our ergonomics a little bit for this patient, but if someone has really bad GI reflux, it's very uncomfortable for them. So anything we can do to alleviate that for them, we will. Blood dyscrasias are more rare. They're rare side effects, and a wide variety of medications can have this as a side effect, but they are rare. It does result in the alterations of blood cell levels. So we're talking about our red cells, our white cells, and our platelets. So there's 4 blood dyscrasias I want you to know about. Leukopenia is a decrease in the number of white blood cells, specifically leukocytes. Leukopenia, leukocytes matches in the blood. Agranulocytopenia is an abnormally low number of granular white blood cells. So granular. So know the 2 of those and associate them. But again, it's a low number. Neutropenia is an abnormally low number of white blood cells or neutrophils. Again, neutropenia, neutrophils. And those are our primary defense against infection. So neutrophils, and you'll learn this in future classes, are our fighters. They fight. They're the first ones to respond if we get any kind of infection. And then finally, thrombocytopenia. This is the different one. This is the reduced number of platelets formed in the bone marrow. So someone with thrombocytopenia is having a reduction in the number of platelets formed in the bone marrow. Patients that experiences blood dyscrasias that affect the white blood cells, so that's leukopenia, agranulocytopenia, or neutropenia, can result in increased infection and reduced healing. So if you think about it, if they have a reduction of these white blood cells, our white blood cells are our infection fighters. Some come sooner, some come later, but if we don't have the correct number of them, we're going to be able to not fight off infections as well, and our healing time is going to be reduced. So if abnormal increased infection is observed in someone and they don't have any other issues that you might know about, then you may need to get them to have some lab work so that we can figure out what is going and if there's any blood dyscrasias that are happening. And then in thrombocytopenia, that's the reduction of the number of platelets that's formed in the marrow. These people can have, it can impair their clot formation because we don't have the number of platelets. Platelets are what helps us clot. So the blood is thinner. So in someone with thrombocytopenia, we're doing the same management and same prevention as we would for excessive bleeding. But for these people, we would need to refer them to a physician. If they're having excessive bleeding, but they're not taking a blood thinning medication, then there may be something else systemically wrong. So if we don't know that they have thrombocytopenia, but this is happening, that might be indication for referral for a medical consult. This lecture, we mainly focused on side effects of medications that could lead to a potential emergency situation. In no means did it cover all of the side effects of medications that a patient could be taking, and there's a lot of side effects that can affect the mouth that are not emergency related. There is a brief description of that in your book, but a very, very common non-emergency side effect is dry mouth, and you'll learn a lot about that in other classes. So for today, I just want you to go home with a take-home note that everyone is different. Not all patients, if they have a side effect listed as of a medication that they're taking, not all patients are going to experience every side effect that's listed. Some patients may never have side effects. Some people might have more extensive side effects than others. The level of the side effect is going to vary from nothing to very little to could be extremely overtaking and they need to change the medication because it's so bad. And that's all going to be influenced by the age of the patient, the gender of the patient, their general genetics, and also dosage. Usually a higher dosage of something increases the chance of having the side effects that it says. So questioning your patients, asking them if they experience the side effects from the medications that they're taking will help you determine if their risk is increased or if you need to modify your treatment appropriately to help prevent against their side effects. After this week, we do have quiz number 2 online. It will be available on Wednesday, and you'll have 1 week to take it. And it'll be over week 3 and week 4. As always, if you have any questions about this lecture, first take a look at your book. It goes into a little bit more detail than my slides do. And then if you still have questions, please don't hesitate to reach me by email. That's pretty easy. I'm pretty good at responding quickly to those. If not, I will see you all on Wednesday for class.